Okay, take two. So weeks 4 and 5 are covered on exam 2. Gonna be set up more so like a med-surg exam with understanding concepts, applying nursing interventions, and a couple application questions, not as many. So let's start with vocabulary first of all. So some of these are going to.
Before you start, so you said application questions. Do you mean like the theory based style question?
Yeah, so there will still be a couple theorists on this exam, but definitely not as many as the first. But the application questions that I were talking about were where we give you a scenario and we want you to use that scenario to find the answer. So okay. Yeah, those type of more so the types of questions that you saw on the first exam. Like if we gave you the age of a child and an activity that they were able to do or not able to do, and then what your intervention was. Those are those application type questions.
Okay.
Yep. So these are going to be a little bit more straightforward, thankfully. So our vocabulary is going to cover some of those hospital concepts especially from week 4. And then also those medical terms that we covered this week in class. So conscious sedation is where we are giving IV medications to impair the patient's consciousness, but still allow them to maintain those protective reflexes. So they can maintain their own airway, they can follow directions, and respond to verbal stimuli. So we typically use conscious sedation if we are doing a short procedure outside of the operating room. That's where you're going to see it most often. A clinical pathway is going to be an interdisciplinary plan of care that displays the entire treatment plan for the patient. So this is going to be really big picture. We're going to have everybody that touches the patient involved. So this is like our nice big snapshot of everything that's going to happen the entire length of hospitalization. So we have to make sure that we have all the different parties involved. And that's our clinical pathway. An emancipated. What do you want me to put in the chat? Oh, you guys should have had the PowerPoint in your announcements with the exam review. Should have been provided in your by your instructor. Let me see if I can drop this in the chat here. Get out. Where's my chat? Here you guys go.
Thank you.
Okay. So an emancipated minor is going to be an adolescent, somebody under 18 that is no longer under their parents' authority and allows them to consent for their own treatment. So we know that military personnel and married adolescents are automatically going to be considered emancipated minors. Outside of that, they should typically have paperwork to show you saying that they're emancipated. But remember, they have protected health information and can control who receives information about them, but they can also consent for themselves. They don't need a parent to sign off on procedures. Regression is going to be a loss of achieved level of functioning going back to a past level. So we will be potty trained, but now we have a regression. So we're going to start having accidents again. We could be consistently using a sippy cup, and now we've regressed and we're only taking from a bottle. So it's moving backwards from where we normally are. And that is just a stress response in our pediatric population. Typically, we see it in our toddlers, our younger kids. As soon as that stress goes away, that regressive behavior will go back to normal. And then this week we covered the rest of the vocabulary. So meningitis is going to be an inflammation of the covering of the brain and the spinal cord, typically going to be caused by group B strep. So brain and spinal cord are going to be meningitis. If we're talking only about inflammation of the brain, that is going to be encephalitis. So brain only is encephalitis. If we have an infection in our bone, that's going to be osteomyelitis. And then an osteosarcoma is going to be a malignant tumor in our bone. Talked a little bit about Rye syndrome, where we have this non-inflammatory increase in pressure in our brain and liver dysfunction. And it is going to be caused by giving aspirin or salicylates to a pediatric patient with flu-like symptoms. So that's why we avoid giving aspirin or salicylates in peds if we have flu-like symptoms. So we don't get this Rye syndrome. Sepsis is going to be a systemic response to an infection. It can be bacterial, it can be viral, it can be fungal. And that overwhelming systemic response can eventually lead to shock and death if it is not treated. Questions on vocabulary?
For the Rye syndrome, is that like to avoid like the aspirin in the children? Is that what it is?
Yep.
Okay.
So anytime a pediatric patient has flu-like symptoms, you don't want to give them aspirin because it puts them at risk. So we're gonna, if we need to bring down a fever or we need to do mild pain control, we're gonna use Tylenol or ibuprofen.
Okay.
Make sure that they don't get aspirin. Yep, we typically try to avoid aspirin just in general in our kids unless we need to give it. Okay. So briefly covering theorists. Again, Freud is all going to be about psychosexual development. So where our focus is. So our oral stage in our infants, we're learning all about the environment with our mouth. So we're putting everything in our mouth. Our soothing mechanisms are all oral related. Our pacifier, being able to put our fingers in our mouth, being able to eat. That's our oral stage. Our anal stage in our 2 to 3 year olds, they're going to be focused on things like potty training and controlling their bodily secretions. So that is our anal stage. Our phallic stage, this is where the Oedipus complex comes into play. And we see boys being attached to their mother, girls being attached to their father. That's our phallic stage. And then latency is 6 years to puberty. And this is where they're going to spend more time with their same-sex peers. So this is that age where the opposite sex has cooties. We don't want to hang out with them. We're going to stay with our same-sex peers, learning those role modeling behaviors. And then once we get through puberty, we're going to be in the genital stage, focusing on those opposite sex long-term relationships. Another part of the anal stage that we see with toddlers is learning how to give and take and constantly saying no. So they are exercising their power and their autonomy by saying no. And that's that negativism. that we see during this stage. That's the only other thing. Do we have questions about Freud? Okay. Piaget is all about cognitive development. So how we think about things. So in our 0 to 2-year-olds, we're going to be in the sensory motor stage. We're learning about our environment by interacting with it, learning how to move through it, using all of our senses. This is where we're going to develop object permanence and realize that objects exist even when we can't see them. Then our 2 to 7-year-olds are going to be pre-operational. So at this point, they're starting to understand things around them, but they may or may not have the vocabulary to express them. So they're going to use symbols for a lot of things, symbolic thinking. So we see a lot of imagination and creativity during this stage. So we'll see them doing things like lining up chairs to make a bus or a classroom. We'll see them using a box as a race car, using symbols to represent things that they may or may not have the vocabulary to express. We also see them developing conservation at this point, where they understand that a tall, skinny glass and a short, wide glass have the same volume, even though they look different. That's going to be the concept of conservation. And then our concrete operation stage, our 7 to 11-year-olds, this is where they're starting to get that logical thinking. They can understand space, they can understand quantity, and they can apply those concepts, but they can't think about them independently. So everything is going to be tied to a concrete situation, a logical explanation for things, something that they've experienced. That's your concrete operational. So a very logical form of thinking. And then finally, we get our formal operational in our 11 years and up. And this is where we have advanced thinking, more so like an adult. So we can think about things that we haven't experienced. We can strategize, think about outcomes, make plans for the future. We can apply concepts from different scenarios. We also get abstract thinking at this stage. So thinking about things that you can't physically put your hands on. So things like vulnerability or justice or freedom, those abstract concepts, something that you can't tangibly interact with, but you understand that it's real. So our sensory motor, again, we're exploring the environment, we're developing object permanence. Pre-operational, we're doing that symbolic thought. So we might sort blocks by color, not necessarily by size or shape. We're going to start giving inanimate objects human feelings. So that's an example of animism. If our teddy bear has an owie, we know teddy bears don't have feelings, but we might say our teddy bear has an owie. And then concrete operations, that logical thinking. We're learning cause and effect. We're going to ask a lot of questions about things, trying to understand why things happen. And then formal operations are those abstract thoughts, that sophisticated reasoning. Questions there? Okay. Erikson is our big one. So our infants are in trust versus mistrust. If my needs are met, when I ask for them, I develop trust. If not, then I develop mistrust. Our young toddlers are going to be in autonomy versus shame and doubt. This is when we're learning how to do things for ourselves. We can dress ourselves, feed ourselves. We're working on potty training, that independent action. Our 3 to 5-year-olds are going to be in initiative versus guilt. So if we say somebody has initiative, we mean they're a self-starter, they're self-motivated. They're going to be one to do something without being asked. So in autonomy, we've developed these independent skills. Now we're going to move into initiative, and we're going to go full force with those skills without being asked to do them. So we're going to take that initiative. Then once we get into our school age, we're going to be in industry versus inferiority. And that's where we're finding activities that give us a sense of purpose and a sense of accomplishment. So industry is going to be focused really specifically on those activities, whether it be school, music, sports, arts and crafts, whatever gives you a sense of accomplishment, that activity is your industry. Our adolescents are going to be in identity versus role confusion or role diffusion. They're both the same. And that is more so those adult decisions. So what are you going to do when you move out from your family? What are you going to believe? Where are you going to live? What's your career going to be? What are your values? Those are all going to be your identity. The rest of them we don't need to worry about because they don't apply to pediatric patients. So examples of a child taking initiative. They might start caring for a pet or a plant. And
Ms.
then,
Styles, I have a question.
Yeah.
Would you be able to go back to the last slide?
Yeah.
So you know how for each age you have 18 months to 3 years,
Mhm.
and then you have 3 years to 5, and then you have 5 to 13. Whenever we're basically being asked about a 3-year-old could either be autonomy versus shame and doubt, or initiative versus guilt. So how would we be able to tell the difference between those when it comes to exam taking? Because I know on the exam, it was a few of them that had 3-year-olds and 5-year-olds rather than in between, like a 4-year-old or
So
if you know what I mean.
yeah, you're really going to have to look into the context of the question and what details they give you. So typically, your 3-year-old is going to be mastering those independent skills. They should be thoroughly mastering those. Whereas exercising that initiative is not necessarily, that's going to be a new concept for them. That's going to be something they're working towards. So really using the context clues in the questions to help steer you which way you need to go for that.
Oh, okay. Thank you.
Help.
Yeah.
Good. So when we're looking at that initiative, we're taking responsibility for something. We might start caring for a pet. We might start caring for a plant, teaching us how to feel responsible and nurturing for something else. The opposite of that is if we neglect our responsibilities, we might feel guilty or unsure of our ability to care for others. So that's that dynamic that you see there. Questions about Erickson? Does that help kind of straighten him out a little bit? Okay. Maslow, remember we start at the bottom of the triangle and we work our way up. So we have to have our basic needs, our physiological needs met before we can move on. So air, water, food, elimination, and rest. Then we're going to be worried about our safety. So our physical, emotional security. Do we have a shelter? Do we have a home? After that, then we're going to be worried about love and belonging. So feeling included. And then once we're feeling loved and included, then we can reach esteem, where we have that sense of achievement. We're being recognized. We have power over our life. And then after we've achieved esteem, we get to self-actualization, where we've achieved our full potential. we're creative, we recognize that we're a special individual.
Miss Styles, vital signs would be considered a physiological need, right?
What was the question?
Vital signs would be considered as a physiological need.
Yes, those are going to be those basic things that you cannot live without. So air, water, food, being able to void or stool, and being able to rest so that you can recover.
Okay.
Yep. And last, for our theorists, we have Kohlberg. So for him, we just need to know pre-operational, conventional, and post-conventional. Sorry, pre-conventional, not pre-operational. Pre-conventional is where we don't understand the difference between right and wrong. We are just in it to make people happy. So we understand certain things make mom and dad happy, and that is our goal. So we are going to do those things, not necessarily understanding the meaning behind them. So making people happy, avoiding punishment. Conventional is our school age kids. So they are going to be very rule oriented. So if you think about it, our kids that are in school, they have a set of rules for at home. They have a set of rules in school. If they do sports, they have another set of rules to follow. So they just understand that they have sets of rules that they have to follow for everything. If they follow those rules, then we are considered a good boy or a good girl. So that is the goal. Again, we're not cognitively aware enough to distinguish what's right and what's wrong, but we do understand cause and effect. So we follow our rules to be a good boy or girl. Then finally, our post-conventional and our adolescents, they are able to understand the difference between right and wrong. They understand morals and ethics. They have that advanced thinking. So they are going to be able to think about long-term consequences and really weigh the benefits and risks of their actions. Do we have questions there? Okay. So we're going to move on to hospitalization. So we want to start discharge planning from the moment that they're admitted. We know that if we wait till the very end of their hospitalization to just dump all this information on them, they're not going to retain any of it. So if we can chunk our discharge planning throughout their hospitalization, parents are going to have a lot better time understanding what we're trying to tell them and be able to retain that information. We want to encourage parents to be at the bedside as much as possible, so we have those opportunities for teaching. Also, it helps to decrease their child's anxiety, having that support person with them all the time so that they're not alone, having to interact with strangers, really helps to decrease their anxiety. We should incorporate home habits as much as we can in the hospital. Again, giving them that consistent environment, knowing what's coming, that same schedule will really help with providing that sense of security. When we're talking about altered level of consciousness, remember that low blood pressure is going to be one of those late signs. Sorry, that's for sepsis. Low blood pressure will cause a lack of oxygen to our brain. We don't have enough oomph to get our blood flowing, then it's not going to perfuse our brain as well. And we're going to have that change in our level of consciousness. When we are planning our care for hospitalized children, we want to make sure that we're reassuring the parents, keeping them involved, letting them know what's going on. We want to maintain that sense of trust with the child and with the parents. So we need to be honest with them. If something's going to hurt, we need to tell them it's going to hurt. We can't sugarcoat and lie to them because we're going to disrupt that sense of trust. We have to be flexible. Not every child is going to present the same way. They're not going to be on the same timetable as we are. We might have, a list of things that we want to accomplish, but their list is going to be very different. So being flexible is essential to being a good pediatric nurse. We talked about incorporating home habits. Those transitional objects also are helpful. So those security items. We want to use soothing techniques to help them play and work through these experiences. We know a lot of times our younger kids don't necessarily have the words to tell us what they're feeling, but if we let them draw or color or role play with a stuffed animal, they might be able to give us clues as to what they're feeling. So using play, making sure that we are incorporating play in different activities to help meet those developmental milestones, and then helping restore them to their normal growth and developmental stage after we do a surgery or a procedure. So one of the things you want to be able to do is identify different interventions for each age group, how you're going to interact with them, how you're going to restore them to that normal sense of growth and development. Separation anxiety is huge in our pediatric population. So it begins at 6 months, peaks at 10 months, and we go through these 3 stages every time we are separated from our parents. So initially, we're going to go through protest where we have that big outburst. We're crying uncontrollably. As soon as parents leave, we're crying out for them. So the interventions to help get through that protest stage are going to be consistent caregivers. So they've already started to establish a relationship with another person. Having those short goodbye rituals, so we have that consistent routine that we're used to. We can use distraction after the parents have left. It's important that we don't let parents sneak out, and then providing that reassurance that the caregiver is going to come back. After the initial protest, they will go into despair, and they're going to be sad, depressed, withdrawn. They don't want to be involved with anything or anyone. So things that can help with despair are those familiar objects. Making sure that parents aren't leaving when they're tired or hungry. And then focusing on something fun when the parents come back. Once we've moved through despair, then we will move into denial and detachment. And this is where we completely ignore the fact that mom and dad are gone. We're going to be back to playing with our toys, playing with our friends, and we are going to ignore mom and dad when they come back. And this is just a coping mechanism for the child to deal with the emotional pain of the parents leaving. So we need to assist in rebuilding that relationship when the parents come back. So helping them to ask questions to their child about what happened while they were gone. Again, we can talk about something fun that they get to do now that mom and dad are back. Anything to help rebuild that relationship. Do we have questions there? Okay. Next up, we are going to look at pain scales. So we need to make sure that we are using the appropriate pain scale for the age and the developmental level of the child. So the top scale here is our FACES scale. That is going to be good for kids that are 3 and older. So it shows 0 to 10, happy face, to the worst pain in your life. And they're going to pick whichever face applies to them. Also underneath are numbers to help correlate with the pain. So if you have a child that's 8 or 9 or older, you can use those numbers for their pain level. For our nonverbal or our pre-verbal children, so like 0 to 3, we're going to use a behavioral pain scale like our FLAC scale. because our patient can't report their pain on their own, we're gonna look at their overall behavior and assess their pain that way. So that way we're not relying on them to tell us what's going on. When we're talking about pain management, remember we have to take the client at their word. Whatever they say their pain level is their pain level. And it exists whenever they say that they're having pain. And it should be assessed with our vitals every single time. When we're giving pain medicine, we want to give low dose medications around the clock on a regular schedule, rather than waiting until we're in excruciating pain and only giving those PRN medications. So that preventative pain plan is what we're going for. Low doses on a schedule. When we're choosing medications, acetaminophen is going to be our drug of choice for mild to moderate pain. For moderate to severe pain, like postoperative pain or a sickle cell crisis or pain related to cancer, we're going to use opioids. And then if we're just doing a topical procedure, like sutures, IV placement, lumbar puncture, we can use lidocaine. And that's just topical anesthetic. Will numb the first couple layers of the skin and get those nerve endings where you're going to be working. And then we talked about conscious sedation. We don't remember it, but we can still maintain our airway, respond to commands. Does anybody know what we use flumazenil for?
Is it for overdose?
Yes, so it's going to be midazolam or diazepam overdose. So Versed or some of your seizure medications. Okay, moving on to our eyes. Our eyes are pretty much just a bunch of terms that we need to know for different conditions. So pink eye or conjunctivitis is where we've got that inflammation and that infection in the mucous membranes of the eyelids. And that is very common in our school and daycare settings. It's extremely contagious, really easy to pass around. Hyperopia are different types of eye disorders. So hyperopia is farsightedness. Myopia is going to be nearsightedness. Amblyopia is going to be our lazy eye, and we're going to treat that by covering our good eye so that we can strengthen that lazy eye. Strabismus, our eyes can't be directed toward the same object. So we've got one eye that will focus on an object, one eye that goes off doing its own thing. And the brain's actually going to disable that eye that's wandering so that the child can get a clear picture. So that is going to be treated the same way as amblyopia. We're going to be covering that good eye so that we can strengthen the weak one. Nystagmus is going to be those jerky movements of the eyeball. So if you're staring at somebody's eyes and you see their eye just fluttering like this, or it could be fluttering up and down, that's that nystagmus. And then papilledema is going to be swelling in our optic nerve. When we are talking about our ears, we have different types of hearing loss. So if we have congenital hearing loss, it means that it's something that we're born with. So it's either a hereditary condition or it could be a result from an in utero infection. So if mom has an infection while she's pregnant, it can result in congenital hearing loss for the infant. So the most common of that is going to be CMV. Is going to be congenital hearing loss is one of the things that we see. Sensory neural hearing loss is when the hair cells along the cochlea and the acoustic nerve are damaged. So the sensors that are going to take in sound are going to be damaged, and that's when you're going to get that sensory neural hearing loss. Then a conductive hearing loss is when our tympanic membrane prevents sound from entering the middle ear. So it's going to be this barrier that doesn't let the sound waves pass. And that's going to be conductive. When we're caring for a hearing impaired child, we want to make sure that we stay face to face and on their eye level. We want to make sure that we establish eye contact before we start speaking to them so that we know that they're paying attention to us. And we want to talk in short sentences so that we give them opportunities to digest the information that we're giving them. And then we have our types of ear infections. So otitis externa is going to be an infection of the outer ear, the external ear canal, or swimmer's ear. And then otitis media is going to be an infection or inflammation of our middle ear. And our first line of treatment is going to be antimicrobials, and typically oral amoxicillin for 10 days is going to be how we're going to treat. Seizures. It's important that you know the different types of seizures and you can identify them. In general, a seizure is a burst of uncontrolled electrical activity between our brain cells, and it's going to cause temporary abnormalities in our movements, our behaviors, sensations, or our awareness. So our types of seizures, we have our grand mal, which is going to be those typical things that you would expect when you see a seizure. So those tonic-clonic jerking muscle movements, they can have shallow and irregular breathing. They might lose control of their bowel and bladder. And then they're going to be followed by that post-ictal state where we've got that prolonged confusion and sleepiness right after a seizure. A petit mal is an absent seizure. So we typically see the child will be interacting with you completely normal, and then their gaze will shift and they'll have this blank stare and they'll stop interacting with you. Typically only lasts a couple of seconds, and then all of a sudden they'll be back with you. So they're just going to kind of lose their focus for a bit and then they're back. A Jacksonian is going to be a partial seizure. So we're not going to lose that full consciousness. We're going to maintain our consciousness or only be slightly impaired. We typically see one area of the body having weakness. So we might see only one arm or a leg, or we might see one side of their face droop. That's going to be that Jacksonian seizure. But they're going to be awake and aware the entire time. Myoclonic spasms or atonic seizures are those jerking motions that happen when they wake up and then they have a sudden collapse and should recover shortly afterwards. So just jerking motions and then we suddenly collapse. And then any seizure that lasts for 30 minutes or more and does not respond to medication is considered status epilepticus. We have a handful of causes of seizures in our pediatric patients. They could be in response to infection, because of a fever, medications, if they have a condition like epilepsy, or hypoglycemia. So if their sugar drops too low, they can have a seizure. It's important that we know our seizure precautions. We want to keep our side rails up, make sure that we pad any sharp or hard object around the bed, make sure we have suction at the bedside ready. Teaching parents to make sure the child has a medical ID bracelet on saying they have a seizure disorder. And then we want to stress the importance of giving their medication at the same time every day and not stopping it suddenly, because we could cause them to go into status. We need parents to provide extra supervision during hazardous activities like swimming. So if a child would have a seizure while they're swimming or while riding a bike, they could be at risk for injury because they can't get themselves out of an unsafe situation. Our medication is going to depend on the type of seizure. Our goal is to control our seizures while producing the least amount of side effects. In your book, table 23.2 has a list of the common medications that we use to treat seizures in pediatric patients. Meningitis, we talked about this being inflammation of the brain and the spinal cord. We talked about group B strep being one of those common organisms. The other one is Haemophilus influenza. If we have bacterial meningitis, we can have intracranial irritation caused by those toxins that get released from the bacteria. One of the signs that we have meningitis is the presence of petechiae, so those little pinpoint red dots that we see. Any patient that is suspected to have meningitis will be in droplet isolation until 24 hours after they've started antibiotics. So they need full 24 hours of antibiotics before we can take them out of droplet isolation. They're going to have frequent neurologic checks. And it's important that we report weakness of the limbs, speech difficulties, any confusion or behavior problems. Those are going to be signs that the patient's deteriorating. They're going to need accurate vital signs, eyes and nose, and they need a nice quiet environment to allow their brain to rest. You will need to be able to identify the different types of fractures and tell the difference between strains, sprains, and contusions. So green stick fractures are going to be an incomplete fracture. So only one side of the bone is going to be broken. The other side is just going to be bent. So I like to think of this as a really young tree limb where you can bend it and it kind of cracks on one side, but it doesn't crack all the way through, still really flexible. That's going to be your green stick fracture. A compound fracture has a wound that goes along with the broken bone. So we've got open skin, broken bone. We're going to be at increased risk of infection because of that open wound there. A simple fracture is going to be the opposite. We have a broken bone, but our skin is going to be intact. An oblique fracture is going to be a complete break, but it happens at an angle. So you're going to see that x-ray and it's going to be this nice diagonal line, and that is going to be an oblique fracture. A spiral fracture happens because somebody forcefully twisted our bone, is typically an indication of child abuse. So anytime we see a spiral fracture, we want to be assessing for potential child abuse. Our sprains are where we have a ligament that's torn or stretched away from the bone, and it results in damage to the blood vessels, the muscles, and the nerves. A strain is going to be a microscopic tear in that muscle or a tendon, and it occurs over time as a result of overuse. So we end up with edema and pain because we've got this long-term microscopic tear. A contusion is going to be a tearing of our subcutaneous tissue that results in hemorrhage, edema, and pain. So a really bad bruise. These are images of those fractures, so you can put a picture with the definition. More bone issues. So we have scoliosis, that S shape to the spine. We assess that in grade school when they have you put your arms together and bend forward at the waist. And you can either see that S-shaped curve of the spine, or you will see one arm will suddenly be longer than the other because of that curvature. Ewing sarcoma is one of our long bone cancers. Leg calf perthes is a disruption to the blood flow in the head of the femur. Juvenile idiopathic arthritis is going to be an autoimmune disease that involves inflammation of our joints, connective tissue, and viscera. If we have oligoarthritis, we are talking about 4 or fewer joints. We can also see this as polyarthritis. And then osteosarcoma is going to be a primary malignant tumor of our long bone. Duchenne's muscular dystrophy is a common condition that only happens in boys, and it causes this progressive muscle degeneration and weakness. One of the telltale signs is going to be those hypertrophied calf muscles. And then torticollis is going to be that limited neck motion. So you're going to see your patient just kind of hanging out like this all the time because of the shortening of the sternocleidomastoid muscle. So traction, we can use traction to treat these fractures that we have. And it helps to guide that bone back into place and stabilize it until it can heal, or we can do surgery. When we have Buck's traction, it is going to pull on the hip and the leg to get that bone back into alignment. So we typically see this in response to a femur fracture. Anytime that we have a patient in traction, we want to make sure that we're doing neurovascular checks to make sure that we don't have a blood vessel that might be pinched in between those bone fragments. We don't have nerves that are being damaged, making sure that we have good blood flow throughout the entire limb. Like we talked about, the purpose of traction is regaining that normal alignment. We're also going to reduce and immobilize that fractured bone. It can help alleviate muscle spasms associated with the fracture and relieves pressure on those nerves, especially of the spine. So traction can be used to reduce our skeletal deformities or those muscle contractures. So when we're doing our neurovascular checks, we are going to be assessing the 5 Ps, making sure that they can feel pain, they have good pulses below the site of injury. We want to assess for pallor, or that pale color, pale or blue. And then paresthesias, making sure they still have sensation down there. And finally, paralysis. They can still move the extremity below the site of injury. Anytime we see a change in our peripheral pulse, so below that site, a change in the color of extremity, cap refill, if our extremity all of a sudden is cold rather than being warm, or a change in that movement or sensation, it indicates that we've got an issue that we need to address. If in the event that we have that pale or blue color to the distal fracture site, then it means that we've got circulation that's compromised and we're at risk for losing that extremity. So that's why our neurovascular checks are so important. Cervical traction is going to be pulling on the skull to lengthen the spine. We can either use a sling device like you see there, or Crutchfield is a type of tong that's used. And then Steinman is a type of pin that is going to be inserted into the bone to provide that traction. For cerebral palsy, that's going to be a group of disorders that affect our movement, our muscle tone, and posture. It's caused by damage that occurs to the brain as it's developing. So we often see this either happening before birth, something happens in utero that causes cerebral palsy, or we have a traumatic delivery. And during the birthing process, we're deprived of oxygen for an extended period of time. We see these signs and symptoms develop during infancy or during preschool years. And overall, we tend to see impaired movement, abnormal reflexes. They're either going to be really floppy and not have control over their limbs, or they're going to have those contractures and that muscle rigidity. One or the other. They're those will affect their posture, their involuntary movements. They may or may not be able to walk. So we can have any combination of all of those things. Spastic CP is going to be those increased muscle tones and those really tense contractured muscles. So spasticity is talking about the tension in the muscle group. Athetosis are these involuntary, purposeless movements that interfere with the child's normal motion. So you can see some of those finger movements that you might see in that picture there. And then opslatinosis is an involuntary arching of the back caused by our muscle contractions. So that posture that you're seeing in the picture there is those muscles being contracted and how the child is all the time. When we're assessing for child abuse, we need to look at all the potential triggers. So whether it's with the child themselves, are they disabled? Are they temperamental? Are they hyperactive? Those social stresses like poverty, unemployment, the family lifestyle. Parental stresses. Do they have a history of abuse? We know abuse tends to carry forward through the family. Do they have low self-esteem? Are they overworked, uneducated? Do they have substance abuse? And then looking for those triggers. So if we have a need for discipline, especially in a child that doesn't respond to discipline and we're having to escalate to get them to give us the response that we're looking for. Also family conflict and financial crises can all put us at risk for child abuse. Understanding the different types of abuse. So we've got emotional abuse where we're tearing down that child's self-esteem verbally. We have emotional neglect where we're intentionally omitting attention to the child. So we're refusing verbal or behavioral actions with this child. That's going to be your neglect. Sexual abuse is any act that is performed on a child for gratification of the adult. And then physical neglect is going to be failure to provide for their basic needs. So that Maslow's hierarchy. Physical abuse is deliberately inflicting injury, so physical harm on someone. One of the telltale signs of abuse are bruises in various stages of healing. So if we have bruises that are all different colors, it can be a really good indication that we've had multiple injuries. We also want to make sure that the story that parents tell us matches the injuries that we're seeing. So if they say, you know, my child just fell when they were getting in the car, but we see a red bruise, a green bruise, and a brown bruise, those don't match. We know we have different stages. We've had multiple injuries here to cause these bruises, not just one event. And then last but not least, we have our same 5 dosage calculation questions that we have on every exam. So make sure that you are familiar with converting pounds to kilograms, being able to use those weight measurements to calculate how many milligrams per kilogram per day or how many milligrams per kilogram per dose. Make sure that you are comfortable with calculating what the physician ordered versus what pharmacy gives you. And then being able to change your answer from milligrams to milliliters based on what the question is asking. And that is it, guys. Feel free to stick around if you have any questions, but that is it for our exam review.